Everyone, in this class we'll learn about anterior pituitary and growth hormone. Pituitary gland. The pituitary gland consists of anterior pituitary, which is also called as adenohypophysis, posterior pituitary, which is also called as neurohypophysis, and intermediate lobe, which is also called as pars intermediata, which is rudimentary. Hypothalamo-pituitary relationship. The secretion of anterior pituitary is controlled by hormones called hypothalamic releasing or hypothalamic inhibitory factors secreted within the hypothalamus itself. They are then conducted to the anterior pituitary through hypothalamo-hypophyseal portal vessel. In anterior pituitary, these releasing and inhibiting hormones act on glandular cells to control their secretion. And posterior pituitary does not secrete hormone. So this is diagram showing the hypothalamus and the anterior pituitary, which consists of anterior pituitary and posterior pituitary, and anterior pituitary related to the hypothalamus through the hypothalamo-hypophyseal portal vessels. Both inhibitory and stimulatory hormones which are secreted from hypothalamus, they run down into the hypothalamic hypophyseal portal vessels and reach anterior pituitary. Posterior pituitary hormones are synthesized by cell bodies located in supraoptic and paraventricular nuclei of hypothalamus. The hormones are then transported in the exoplasm of nerve fibers to posterior pituitary. Axons that arise from the supraoptic and paraventricular nuclei of hypothalamus pass to the posterior pituitary via hypothalamo-hypophyseal tract. The nerve endings contain secretory granules which are called as herring bodies, and they secrete ADH or which is also called as vasopressin and oxytocin. So this is the hormones of posterior pituitary are actually synthesized in the hypothalamus, that is paraventricular nucleus and supraoptic nucleus, and through the hypophyseal tracts they are going to reach to the posterior pituitary and they are transported along the nerves by the axonal exoplasmic flow. Pituitary hormones from the anterior lobe are TSH, ACTH, growth hormone, FSH, LH, prolactin, and beta lipoprotein are secreted, whereas from posterior lobe, the antidiuretic hormone and oxytocin are secreted, and from intermediate lobe, alpha and beta melanocyte stimulating hormones are produced. Coming to the growth hormone. Growth hormone is also called as somatotrophin or somatotrophic hormone. It causes growth of almost all the tissues of the body that are capable of growing. Somatomedins are nothing but they are the polypeptide growth factors secreted by liver and other tissues. The effect of growth hormone on growth, cartilage, and protein metabolism depends on the interaction between growth hormone and somatomedins. They're also called as insulin-like growth factors, that is somatomedins. They're also called as insulin-like growth factors, and their effect on growth are similar to that of insulin on growth. The principal circulating somatomedins are insulin-like growth factor 1, which is also called as somatomedin C, and insulin-like growth factor 2. Metabolic effects of growth hormone. On protein metabolism, growth hormone has an anabolic effect on protein metabolism. It increases amino acid uptake into the cells. It increases protein synthesis in ribosomes, which is going to enhance the RNA translation. And growth hormone stimulates the transcription of DNA to form RNA. It decreases the catabolism of protein and amino acids. On fat metabolism, the growth hormone increases the levels of circulating free fatty acids. It mobilizes the fat from adipose tissue and it enhances the conversion of fatty acids to acetyl-CoA. It has a protein sparing effect. Free fatty acids are utilized for energy and thus decreases the breakdown of the cell protein. And they have a ketogenic effect, that is excessive amounts of growth hormone, mobilizes more free fatty acids so that large quantities of acetoacetic acid are formed in the liver and released into the body fluids. On carbohydrate metabolism, that is growth hormone is a diabetogenic hormone. It increases the production of glucose by liver. It increases the insulin production and decreases the sensitivity to insulin, that is uh, insulin resistance. Hence, it decreases glucose uptake on adipose and skeletal muscle. See its effect on electrolyte metabolism. Intestinal absorption of calcium is promoted, and renal excretion of electrolytes like sodium, calcium, phosphate, and potassium is suppressed. And it also causes retention of electrolytes and diversion of those electrolytes to the growing tissues. Actions on growth. Before the closure of epiphysis, growth hormone increases the length of the bones. It stimulates proliferation of chondrocytes and osteogenic cells. Protein deposition by chondrocytes and osteogenic cells are increased, and it causes conversion of chondrocyte into osteogenic cell, thus causing deposition of the new bone. Growth hormone stimulates osteoblastic activity, which converts cartilage into bone. And after uh, closure of epiphysis, linear growth is not promoted. Bone thickening can occur through the periosteal growth. And this is how the growth hormone secretion is regulated. So growth hormone is regulated mainly by the hypothalamus by growth hormone inhibiting hormone, growth hormone releasing hormone, which are going to inhibit and increase the secretion of growth hormone from anterior pituitary respectively. Then growth hormone stimulates the liver to produce somatomedins, and somatomedins, by negative feedback, they're going to decrease the release of growth hormone, and they also can stimulate the growth hormone inhibiting hormone from hypothalamus. The stimuli that affect growth hormone synthesis are the secretion, stimulate the growth hormone secretion are decreased blood sugar, that is blood glucose levels, decreased blood free fatty acids, starvation or fasting, protein deficiency, trauma, stress, excitement, exercise, testosterone and estrogen, deep sleep, particularly stage 2 and 4, and growth hormone releasing hormone are going to stimulate the production or increase the production of growth hormone, whereas some of the hormones, they are going to inhibit the hormone secretion. They are rather factors: increase blood sugar levels, increase blood free fatty acids, aging, obesity, growth hormone inhibitory hormone, which is also called as somatostatin, and growth hormone, that is exogenous growth hormone, and somatomedins, which are also insulin like growth factors. They are going to inhibit the growth hormone secretion. Coming to applied aspects, gigantism. Gigantism occurs due to the hypersecretion of growth hormone in children before closure of epiphysis. It usually caused due to the tumor of pituitary gland. Some of the clinical features are: there will be abnormal height, that is, the person can grow up to 6.5 to 9 feet. They have a large hands and feet. There is a bilateral gynecomastia, and there will be loss of libido, and there can be impotence. Then hyperglycemia will be caused by growth hormone, which leads to excess insulin secretion. Overactivity of beta cells of pancreas ultimately leads to degeneration of these cells and deficiency of insulin, resulting in diabetes mellitus. The tumor of pituitary gland itself causes headache and visual disturbances. Sometimes there can be bitemporal hemianopia. If untreated, gigantism ends in hypopituitarism due to the destruction of the gland by the tumor. Treatment of acromegaly or gigantism is usually irradiation of the tumor, if at all it is caused due to the tumor. Acromegaly. This occurs due to the hypersecretion of growth hormone in adults after the closure of epiphysis. It can be caused by extrapituitary as well as intrapituitary growth hormone secreting tumors and by hypothalamic tumors that secrete growth hormone releasing hormone. The height will not be increased, but bones become thicker and soft tissues continues to grow. Hypersecretion of growth hormone is accompanied by hypersecretion of prolactin in 20 to 40% of the patients with acromegaly. Some of the clinical features of acromegaly are hands and feet are enlarged, especially the acral parts, that is peripheral parts, and there will be protrusion of the lower jaw due to the elongation and widening of the mandible, which is also called as prognathism. There will be overgrowth of malar, frontal, and facial bones combines with prognathism to produce coarse facial features called as acromegalic faces. The changes in the vertebra will also lead to condition called as hunchback, that is kyphosis. The skeletal changes predisposes to osteoarthritis, and excessive growth of the internal organs lead to cardiomegaly, hepatomegaly, splenomegaly, and renomegaly. There will be excessive growth of body hair, so there can be bitemporal hemianopia, which occurs because of the optic chiasma is compressed due to the pituitary tumor. In 4%, there will be gynecomastia with or without lactation. So treatment, the benign tumor will be usually treated by surgery followed by irradiation, and malignant tumors, they are usually treated by irradiation and surgery usually not done. This picture shows some of the clinical features of acromegaly, where it is showing prognathism and acromegalic faces, increased hair growth, that is hirsutism, gynecomastia because of the increased prolactin levels. There can be osteoarthritis, importantly enlarged hand and feet. There can be organomegalies like cardiomegaly, splenomegaly, renomegaly, and hypertension. And there can be osteoarthritic changes, that is vertebral changes, which leads to kyphosis, and there can be visual field defects like bitemporal hemianopia. Dwarfism. Some of the endocrinal causes of dwarfism are pituitary dwarf, where it occurs because of the growth hormone deficiency. It is due to the growth hormone deficiency secondary to decrease in the growth hormone releasing hormone. Some of the characteristic features are plumpiness, that is fatness, immature faces and small genitalia, delicate extremities, delayed skeletal and dental development. And there can be hypothyroid dwarf, which occurs because of the deficiency of thyroid hormone in children, which is also called as cretinism, and it is due to the thyroid hormone deficiency. The difference between pituitary and hypothyroid dwarf is given in the table. The genetic cause of Laron dwarfism, that is also called as growth hormone insensitivity syndrome. Here, the plasma growth hormone levels is normal or elevated, but the growth hormone receptors are unresponsive. So this occurs due to the mutation in the gene for the receptors. And there is also marked decrease in the plasma levels of insulin-like growth factors 1 in this condition. So this table shows some of the difference between pituitary dwarf and hypothyroid dwarf, which is also called as cretin. Pituitary dwarfism occurs due to the growth hormone deficiency in childhood, and cretinism occurs due to the thyroid hormone deficiency in children less than 2 years of age. The mental activity is normal in pituitary, where the cretin dwarf is mentally retarded. The pituitary dwarf is sexually mature and cretin is sexually immature. In pituitary dwarf, different parts of the body are proportionate, whereas in cretinism, the different parts of the body are disproportionate. That is, upper segment is more compared to the lower segment. African pygmies, they have a normal plasma growth hormone levels. Plasma concentration of growth hormone binding protein decreases here. The plasma insulin growth factor 1 concentration fails to increase at the time of puberty. Some of the nutritional causes like marasmus and rickets also lead to dwarfism. Achondroplasia, it is an autosomal dominant condition caused by mutation in the gene that codes for the fibroblast growth factor receptor. So there is a faulty uh, endochondral ossification resulting in dwarfism. Here, subject is mentally sound, and it the features are abnormal body proportions, like they have a large head and short limbs. So this is in brief about anterior pituitary and the growth hormone. Thank you.